Fiona and Miriam, thank you for joining me.
Hi. Good morning. Thank you.
Thank you. So, discussing the topic of centralised decision-making in highly specialised care, Fiona, as Deputy Director of Clinical Commissioning of Highly Specialised Services in the NHS in England, could you briefly explain your journey to healthcare commissioning? And for someone who may not be familiar with the term, what does commissioning refer to in healthcare? And what is the role of patient community engagement within that?
So I did originally a degree in biochemistry, but I decided that I didn't really want to be a sort of pure scientist. I wasn't quite sure what to do next. So I got a temporary job as an administrator in a health authority in 1991. And I earned £4 an hour then. I've had lots of jobs in the NHS since then. I love the fact that I can use the knowledge from my degree, even though it was a very long time ago, to help discussions with clinicians and to have a good understanding about how new drugs and treatments work. In terms of what does commissioning mean, we're allocated a national budget for the whole of England to pay for provision of certain healthcare services. There are three main parts to it. First of all, it's about assessing the need of that particular patient population. This is about understanding the condition or the disease and the various facets of care that are needed. We also need to understand how many individuals might need the service. Once we have that information, we write what we call a service specification, which sets out our expectations of what a healthcare provider needs to have in place in order to care for the patient group. And we use this specification to select the right providers to deliver the service and to agree a formal contract with the successful ones. And once that service has been mobilised, we make sure that it's offering the high quality service we would expect. One thing that's really important to understand what needs to be delivered in the expert centre and what can be delivered more locally, either another provider, perhaps through what we call a shared care agreement. And that improves the knowledge and practice of local clinicians with extra support from the expert centre or using virtual technology. You know, COVID has accelerated some of that. And we've also developed a toolkit about how to deliver virtual clinics for patients who've got rare diseases and who have multi-system disorders. In terms of collaborating with patient community, this is a really essential part of how we work. I can't possibly know what's important to patients and families about their particular condition. And if I try and guess, I would always get it wrong. So, for example, I commission services for patients who have spinal muscular atrophy, and I assume that any sort of walking would be the most important thing to that patient group. Whereas what I've learned is that it's actually upper limb movement that's important for independence, you know, for, say, transferring from a wheelchair to a chair to a toilet, and also being able to use digital devices. And if we do develop a service specification, we always have patient and public voice reps on that group to develop the specification. We usually have public consultations about our specifications to make sure that we've captured all the right information. And we always have a PPD rep when we evaluate bids from providers for new services.
Thank you for ending on the point about the importance of patient community engagement within the work of commissioning, which brings me nicely onto my next question to Miriam from SOMA. Miriam, of course, SOMA is the German patient organization for anorectal malformations and Hirschsprung disease. Could you briefly explain your role at SOMA and why you became involved with this patient organization?
Yeah, so I first got involved with SOMA through my youngest son, who's affected by multiple malformations, one of which is an anorectal malformation. And I quickly realized that the troubles we were facing with finding specialized surgical care and follow-up care, lifelong care, is shared by nearly every family affected by complex malformations in Germany. Not only anorectal malformation, but also other complex congenital malformations. And I learned that SOMA, over the last 35 years of its work, has been advocating for centralization of care in Germany, and how through the initiative of SOMA and other patient organizations, national and international networks were created. But despite all these efforts, the care situation in Germany remains extremely decentralized up to today, with a vast majority of pediatric surgical units performing less than 5 corrective surgeries per malformation per year, and some of them not performing these surgeries each year. So despite Germany being a big enough country to have around 300 cases per year of anorectal malformations and about 160 cases of Hirschsprung disease, the case numbers per hospital are much lower than in smaller European countries that have less cases but policies for centralization. So my main point is that the rarity of a disease is not our main problem if we have good health policies in place to create a good distribution of cases. In the discussions I was privileged to participate in, I quickly realized that we have little chance of being heard with the problems we face as families unless we have good data to describe the care situation and its effect on the outcome of our children's health. So while through the various networks such as CureNet, ARMNet, and the ERNs, Eurogen and Ernica, an abundance of clinical works and guidelines, and also obviously the immensely important operational criteria for the ERN centers is available, little was known about the care situation as a whole in Germany. So as a consequence, my areas of interest and my voluntary work for Soma now focus on, firstly, to research the volume-outcome relationship for complex malformations. Secondly, to analyze data and make it accessible and hopefully more transparent on caseload of highly specialized surgery through routine databases. And thirdly, to find somehow political ways of influencing centralization policies such as mandatory minimal caseloads for the elective corrective surgeries for complex malformations.
No, that's interesting and definitely ties to the system that Fiona has described with regard to highly specialized decision making. I'm sure England is an interesting case study that you maybe look to within the German context for ideas about how things could potentially be improved. Fiona, you've touched on how your team does so already, especially with regard to patient engagement. But can you outline for us in more detail how your team decides on and oversees the provision of highly specialized services? And in particular, I'd be interested to know what exactly makes a service highly specialized, resulting in its centralization in NHS England.
So generally speaking, highly specialised services are delivered in about 3 centres in England and have a patient caseload of 500 or fewer. Some caseloads are much smaller than this. Some are a little larger, for example, liver transplants, but these are commissioned centrally because there's a benefit from having national coordination. Our services have to be distinct from a clinical point of view. They can't just be one complex procedure in a bigger service. Why do we do this? Well, what it means is that a patient from England, regardless of where they live, can access a high quality healthcare service, good clinical outcomes that are regularly assessed. And these centres are much more likely to be the ones that undertake research. And another factor is that it's only these centres that are reimbursed financially to deliver the service. We formally commission around 80 highly specialised services. We've also got 20 rare disease collaborative networks. These are broadly based around the concept of the European reference networks and bring together providers from across the UK who have an interest in developing understanding of a particular rare disease and are committed to working together to progress research, increase knowledge, improve patient experience. They're research active in a particular rare or very rare disease. And we try to use the principle that where practical, knowledge moves rather than the patient. And we encourage these rare disease collaborative networks to collaborate internationally. And they are awarded an NHS logo so that they can put that on their website. They can be, recognised as having expertise, and they can also use it to raise awareness with other clinicians and patients.
That's interesting and definitely a sort of multifaceted approach, isn't it, to addressing highly specialized healthcare. And it's interesting how what falls within the realm of highly specialized healthcare is determined. Miriam, you've sort of done so already with regard to what your organization advocates for. But could you explain to us what challenges families in Germany face in accessing highly specialized healthcare for specifically anorectal malformations and Hirschsprung disease? And are there perhaps elements of the UK's centralized system, which Fiona has described, that you believe could be sensible in Germany?
Yes, so the main challenges for people with anorectal malformation and Hirschsprung disease are also shared by people affected by any complex malformation. So this is why we work closely together with respective other German patient organizations such as KEKS for the esophageal atresia or BEG for bladder extrophy. Our problems are always the same. Most of the gastrointestinal malformations are not diagnosed prenatally. So families learn about these diagnoses in the early postnatal period. So time is a major factor, and that distinguishes these congenital malformations from maybe other rare diseases where time might not be such a big factor. Families then find themselves in any of the hospitals providing perinatal care. And for AIM, we found that the roughly 300 cases per year were born in 360 different hospitals over a 7-year time period. So some of the hospitals not even having one case per year. This distribution cannot really be addressed by any health policy since the diagnosis of ARM or also Hirschsprung disease is not known up to that moment. However, the most complex and life-defining intervention for these malformations, the corrective surgery, can always be planned. And still, we found that in the years 2020 to 2022, the 350 corrective surgeries for anorectal malformation were performed in 117 hospitals, of which only 25 reached a minimum annual caseload of 5. And 47 were performing one or fewer corrective surgeries. And this problem can be addressed by effective centralization policies, but these do not exist in Germany for pediatric surgery at the moment. And we did see that nearly no pediatric surgical unit transfers these complex cases. The same problem existed in adult surgery in Germany, and it has been targeted. But at the moment, it is up to the parents to find a way to specialized care. But I just need to stress in this very early moment of the patient journey, parents are often not even aware that the diagnosis is rare and complex. We face hospitals informing wrongly about the amount of cases they treat or downplaying the complexity of the malformation. We have parents reporting that they were told their child cannot be transferred and that the operation might be urgent. So even if parents want to get information on the quality of care on a specific malformation in a certain hospital, very little information is publicly available. There is up to today no transparency on case numbers. There's no chance for parents, even if they do suspect that the operation might be rare and complex, to find out which hospital has what kind of caseload. And most of our members contact us after corrective surgery was performed. So in many cases, we believe that they do contact us too late, and many voice regret over not having had knowledge about the care situation and the complexity of the operation prior. Some members report lifelong problems due to a low quality of care during the time of corrective surgery. In other surgical specialties, the problem of low case volumes per hospital for highly specialized care was addressed by different measures. We have voluntary certification processes. These do exist as part of the ERNICA certifications and the EUROGEN certifications, but we did see in our numbers that neither of them changed the numbers of hospitals participating and the distribution of case numbers. So voluntary certification processes are needed to state the ideal, to show what would a center look like. But they are unfortunately not an effective policy for centralization, as those hospitals who are not centers will just continue to provide specialized care. And for adult surgery, mandatory minimal caseloads were first introduced in 2010. But the interesting thing is that they only were put into effect when they were linked to reimbursement. And that was in 2019. So for 9 years, the law already existed that there is a mandatory minimal caseload, but hospitals continue to provide care until the day when it was not reimbursed. So we believe that this is also the strategy that could work for the corrective surgery for complex malformations.
See, that's really interesting. It sounds like there are many obvious illogical shortcomings in the way that highly specialized healthcare decisions are made in the German system, perhaps, especially at the regional level and for anorectal malformations. And it sounds like there have been regrettable consequences that your organization has become aware of. That's really interesting. Fiona, asking you another question, and perhaps somewhat reflecting on what Miriam has shared. Of course, all national systems have their positives and negatives, their strengths and weaknesses. What is it in NHS England that is being done to, in England, further enhance the centralised decision-making process for highly specialised care? We've heard about the value and importance of highly specialised care for in rare diseases, but is there anything that in the appreciation of that is being done in NHS England to even further strengthen highly specialised healthcare decision-making?
I guess the one sort of increasing area is about making sure that patients with rare diseases get timely access to drugs, including gene therapies. What we've seen over the last few years is that the number of drugs available to patients with rare diseases has rocketed. And sometimes they're quite complex to deliver. And it's really important that the expertise in making choices about those drugs is still in a small number of expert centres. And we do this by making sure that we get really early engagement with pharmaceutical companies, providers and patient groups. We do horizon scanning to make sure that we're aware of any complexities in delivering a drug and how it's going to interact with the existing patient pathway. So I'd say that that's probably the biggest increasing area for us, is making sure that when those drugs become available, that the right patients get them and they get timely access to them.
So that's very interesting, Fiona, to hear about the areas where you're endeavouring to further enhance the decision-making processes on highly specialised healthcare in England. Miriam, reflecting on much of what has been discussed today, what is your perception about the readiness of the German health authorities or German policymakers to improve the system in Germany for decisions on highly specialized care? What are the changes that your patient organization is calling for? And does your organization perhaps feel optimistic or pessimistic? What's your take?
I think all of us at Soma feel very optimistic. We see better chances to achieve meaningful centralization policies in Germany than ever before. I think the German health authorities and also the National Assembly of Insurances are aware that centralization of highly specialized care improves outcomes and cost effectiveness. So we are looking forward to see a better future for the children being born with complex malformations. In the process of this realization, there are still some obstacles for us as a patient organization. We always face the obstacle that we are still not recognized as equal partners in negotiations or planning processes on a political level. Some processes do not include us at all. In some processes, we are only involved at a very late stage when major decisions have already been made. It is up to us to raise awareness that we need to be heard, that we have to offer expert opinion, and that we do have to offer a very good national and international network of experts and also good data analysis, and most importantly, a holistic view on the needs of patients, completely free of any conflict of interest. So the efforts of Eurodis and the ERNs is still very much needed, also for us on a national level, to continuously highlight the importance of involvement of patient organizations. And we can only benefit from that in our German setting. And another problem we face is somehow whoever screams the loudest gets heard. And in politics, in a health system that is currently facing many problems, a lot of people try to raise awareness to their problems. So we do represent quite a large group of patients, but certainly issues like the treatment of cardiovascular problems in adults or oncological problems in adults are a much bigger group of patients. So one of my current research work is focusing on the financial impact of complex malformations on the German health system, because we need to consider, despite the fact that we are not a very common, we don't have common diseases, we have a low incidence disease. Our members and the patient affected by these complex malformations usually live a full lifespan, and they need constant medical care depending on the quality of pediatric surgical care during their childhood years. So the financial impact we have on the system is much bigger than the incidence of diseases might have people think. And the third biggest problem is that medically, the treatment of complex malformations is quite difficult and complex to understand. So good public health strategies need to be based on sound medical understanding of the specific malformations. So politicians and public health experts need to be advised by clinical specialists. And unfortunately, still some of those advising are personally interested in keeping a decentralized health policy. So in that context, our patient involvement is more important than ever before.
That's a really important point. Thank you, Miriam. Those are some really interesting reflections. So today's discussion has, of course, focused around ideal national approaches to commissioning and making decisions on highly specialized healthcare. But of course, this is also an area where cross-border collaboration is very important. The final question I would like to put to both of you is, what would be your general argument for greater cooperation between European health systems on commissioning highly specialized care services? Fiona, I'll ask you the question first, and then I'll go to Miriam.
So, yeah, the huge benefit of our system is that we're able to restrict which providers can deliver a service. And it means that we can monitor the quality of that service, and we can ensure that patients in England get access to a good service, regardless of where they live. The biggest challenge, and Miriam's alluded to it, is that countries need to sign up to the principle of commissioning services in a highly specialised way, i.e. restricting which providers deliver the service. But they've also got to sign up to the outcome, because it does mean that by restricting that access, you get good quality of care, but not every provider is going to be able to deliver the service.
Well, that's interesting. And Miriam, what would be your argument for greater cross-border collaboration in this area?
The way that the European health system can help us is to set an example of where we need to aim. This is what the European reference networks already do. They set an example of the ideal, and we can use them in our national discussions and say, this already exists on a European level. So why are we not able to have this on a national level? And then hopefully from there we can go the next step. And for the ultra rare diseases that even a country as populated as Germany is too small for, then we can look at cross-border solutions. We do have the big advantage that for some of the not ultra rare diseases, but more rare diseases, we have enough cases in Germany. But we need to organize the distribution in Germany much better. And we do need the continuous help of the European Union for that.
That's interesting. No, there have been some really interesting points and reflections and learnings from this discussion on highly specialized healthcare. Fiona, Miriam, thank you very much for joining me for this discussion. It's been really enlightening and informative, and I found it very enjoyable. Thank you, Fiona, and thank you, Miriam.
Okay.
Thank you.
Thank you.